Hello and welcome to my presentation. My name is Kylie Prentice and I'm a third-year medical student at the University of California at Irvine Medical School. My poster presentation today is an abstract describing a clinical vignette. Without further ado, here it is. A case report of autoimmune pancreatitis masquerading as pancreatic cancer. To introduce this topic, the presentation of obstructive jaundice with a pancreatic head mass seen on imaging is highly concerning for pancreatic adenocarcinoma, which is the third leading cause of cancer-related death in the U.S. The purpose of this clinical vignette is to highlight a very rare cause of this presentation that carries a significantly better prognosis, type 1 autoimmune pancreatitis. A 75-year-old male with diabetes mellitus, hypertension, and hypercholesterolemia presented with 3 days of weakness. Vital signs were within normal limits, and physical exam showed scleral icterus and jaundiced skin. Total bilirubin was 15, and direct bilirubin was 8.7. MRI imaging showed pancreatic ductal dilation. The patient was admitted in anticipation for an endoscopic retrograde cholangiopancreatography. Meanwhile, magnetic resonance cholangiopancreatography findings included the double duct sign with a 3.6 centimeter pancreatic head mass. This sign signifies dilation of both the common bile duct and pancreatic duct and is highly suggestive of pancreatic adenocarcinoma in a jaundiced patient. ERCP found common bile duct dilation due to pancreatic head mass obstruction. Mucosal biopsies were obtained and the duct was stented. Within a few days, the patient's jaundiced skin and scleral icterus thankfully improved. Total bilirubin was 10.7 and direct was 5.4 at the time of discharge. Of note, serum IgG levels were obtained given that ERCP found a suspicious appearing hypoechoic pancreas, suggestive of IgG4 disease. IgG was 1,777 with IgG4 at 456. Interestingly, cytology results showed benign glandular, acinar, and stromal tissue present with no malignant cells. Biopsy results showed 6 IgG4 positive plasma cells per high-power field, confirming the diagnosis of IgG4 disease causing autoimmune pancreatitis, also known as AIP. Next, we have a few classic images for your reference to demonstrate AIP. Image A is an H&E stain of pancreatic lobules being replaced by severe inflammatory cell infiltration and fibrosis in the pinker areas. Image B is another H&E stain where the lobular interstitium is infiltrated by plasma cells, lymphocytes, and a variable number of eosinophils. The arrow in the upper right corner points to residual atrophic pancreatic acini. Lastly is a classic image of the double duct sign on coronal MRCP, where both the common bile duct and pancreatic duct are proximally dilated. Now for our discussion. IgG4-related disease is a sclerosing and autoimmune process that encompasses many different organ systems and can manifest in one or multiple organs. Type 1 autoimmune pancreatitis is one such disease under this umbrella. AIP can manifest variably as a mass, hepatobiliary strictures, pancreatitis, or even involving salivary glands, lungs, and kidneys. This disease is more commonly recognized in Japan, where an epidemiological survey in 2011 reported the prevalence and incidence as 4.6 and 1.4 respectively per 100,000 in the population. While rare, this is an important diagnosis to remain on the differential. AIP can often masquerade as pancreatic cancer, leading to unnecessary surgery and potentially harmful chemotherapy. One study found that 8.4% of patients who underwent pancreaticoduodenectomy for suspected malignancy in fact had benign disease, with a third attributable to AIP. In conclusion, our case highlights a classic presentation of pancreatic adenocarcinoma with a final fortunate diagnosis of the rare AIP. AIP should be on the differential diagnosis of those with pancreatic head masses yet unconfirmed by pathology, as such a diagnosis can limit unnecessary surgery and burden on the patient. This poster was created by myself, Dr. Sarah Azam, and Dr. Ali Tatanjian. We would also like to acknowledge Dr. Cameron Harding. Thank you, ACP, for your attention and consideration.